Calling to order, Health and Family Services Committee.
Mrs. Geiger.
Here.
Ms. Vedder. Mr. Ruiz. Mr. Steingart.
Here.
Mrs. Labuda.
Yeah.
Okay, thank you everyone for coming. I'm sure my colleagues, the rest on the board, will trickle in as we go along. We're going to start off with our Division Health and Family Services Monthly Report, which is attached to the agenda.
I think it's actually the second report in
The second report, the first report we'll hear in a brief presentation a little bit further along. Anybody need agendas? They're here. Okay, Commissioner Parker.
So can I make any excuses for not being 100% prepared because my secretary's enjoying her vacation this week?
I read through the report and it
No,
looks
but
like you were prepared, so I'm not, I'm not concerned.
So I just to touch on a couple of highlights in this month's report. I'll start with the Adult Care Center. We do have a marketing outreach coordinator. That position was created to help once the facility was renovated and the 4 units were established, and a comprehensive marketing plan is in the process of being developed. And then we all have the unfortunate news with Mr. Jesus resigning, but we are all very excited with our new hire, and I know I see Shanoy is going to be introduced, you know, a couple items down on the agenda, but we're happy she started, and I'm always happy when someone comes back the second day. And I'm being truthful when I say that. Under community services, and Joe is here, but the section here where, you know, he notes a significant increase in those individuals presenting with an opioid or heroin addiction and being referred to higher levels. I know that there is a lot of cooperation going on between community services, public health, area law enforcement in terms of responding to increases with these substances. I'm trying to be kind of quick here. So under the family services, under fraud investigations, 873 active investigations, 260 referrals during the month. In total, since the 15 became in existence, there are over 70 arrests. Under the Office for the Aging, this is more of a divisional. The home delivered meals, the ACC staff, kitchen staff prepare the meals for the folks who are delivered meals at home, and there were kind of a couple bumps in the road, communication issues, etc., that the respective department heads are working on. I think we had an issue with hot dogs being delivered with no hot dog buns. Things happen, so they are communicating regularly on that program now. But they cook a whole bunch of meals every day in the ACC, and Debbie DeHaze, who's part of, when I met with her before she left, she said in the entire time she was there, she only received 1 complaint about the quality of the food. So I think that's good.
Mm-hmm.
And then those were really the areas that I highlighted in the monthly report. I don't know if anyone has questions from the monthly report.
I have questions. Randy, I just wanted to ask 2 things. From the fraud investigation, I see that the unit has had, financial recoveries. And I just didn't know if you had like a total.
In the fraud unit, there's an investigative part of the unit, and then there's the resource recovery part of the unit. I think the thing that, you know, I've seen tremendous progress, and in a meeting that I had the other day with some staff, remember we did the contract, the county did the contract with Zager Law Firm in terms of collections on behalf of the department, and we turned over 5,000, I think there's 5,000 cases to be turned over. They are doing it by the alphabet. They are through the R's in terms of what they, starting with A, in terms of what they have turned over. And then the law firm sends us over cases where they have proceeded with collections, and the report that I saw the other day, there were over 1,100 cases entered in, and the total to be collected is 1.5 million with those 1,100 cases. Now, I think in total, we were looking at probably 5,000 cases with over 5 million. But in the months of August and September, you know, any new initiative or thing that you start, you have a ramp up period of time. But in August and September, I don't think that the firm took much vacation, and they did a ton of work in terms of those collections. So that's, you know, over 1,100 cases entered in where they're in the process of, and these are repayment agreements that benefits were issued over years, and they are going back, I believe, a 7-year period. So we have some outstanding repayment agreements from that long ago that are now being collected upon. So I mean, that I think that was a great contract that we entered into, and you know, it's good to see that money is now being sought out.
So that had been recognized at one point, that, you know, there was possible financial resources there, because ultimately that money there that is recouped from the fraud investigations comes back to the division?
I mean, it depends on if it is Medicaid money, if it is safety net, SNAP, you know, repayment agreements. Sometimes in an emergency situation, a family will come in and they may not necessarily be categorically eligible for an emergency situation, but there are, you know, a couple other options where you can grant them emergency assistance with a repayment agreement. And with the repayment agreement, we're focusing on those repayment agreements and recouping that money.
Right, and initially, you know, when the whole fraud investigation unit began, the goal was to preserve Medicaid money for the needy and not to have it, you know, go out in any fraudulent activities. So, you know, if it looks like $1.5 million, that's a tremendous success, and still more to go.
And I think the important part is there is a system now to put these repayment agreements into, and then in a process in which it will, right now we are cleaning up and it's going well, but there's a system now, there's a structure in place to continue to do this.
Which we didn't have before.
Right.
Right. Okay, and my other question evolved around the numbers for the Medicaid on the, we're down on one of the, let me see. Or was that in my notes, I believe? The cases, oh yeah, how come I don't see that in here? All the way down. Oh, yeah, yeah. Where's that, caseloads? In the MA?
On the monthly caseload report?
Yeah. Or was it actually the TANF?
No, it's the PA TANF. I mean, we've been talking about that pretty much all year, where when you see each month, you're seeing those numbers decrease. on the PA Tanning.
10%, is that what I got there?
Well, if you go from 418, from previous month it was 418, it's 408, but it looks like each month is the lowest month in the previous 3 years, is the trend that is happening in the PA Tanning.
And also.
And also
the
with safety,
net?
and also with safety net, each
Right.
month is the lowest month in a 3-year period. So that is, that's significant.
And so what are we contributing those numbers to?
I mean, these are the folks that are truly without any resources, okay? I think a little bit, and it's obviously, a little bit controversial from, there's two sides to every story. I think that folks are not coming who are not truly residents from Sullivan County. I think the activities of the feds, the front-end detection system, are denying more applicants who are not eligible. And I think that has had a true impact on the numbers. And the folks who truly need and are eligible for the service are receiving it.
Because in reviewing, I'm just gonna mention the, placement of the homeless in the motels, and, I know Giselle had given a report last month with the numbers, and, shortening the time that, they would be in temporary housing and moving them into more permanent housing, such as apartments with kitchens. It had to be, the motel placement, when we did the tour, 2.5, 3 years ago, seeing some of these people, I think there was an average of 200, over 250 something. And, motel placement sometimes 8 months, a year was not uncommon. And so what we did here with this legislative board and with the help of the commissioner and staff was to transition those people out of motel placements into permanent apartments that they can cook and try and make connections with families. I know Giselle had the summary last month of the numbers of people that were connected ultimately with a family connection, which is, if you look at where we had been and where we've come now, better for the individuals that are homeless to be in a more permanent situation, in an apartment with a kitchen and, case management. I know we set up the managed housing. If you could just kind of explain how that's going. Because I know we initially looked at a model in Ulster County, we looked at housing model in Delaware County. Ulster was very costly, Delaware did it a little differently, so from that model, we set up the managed housing in Monticello to start off.
It has 6 gentlemen in it still, as they transition to housing on their own, because again, that's kind of transitional for us to move them into permanent housing as well. So as they transition out, we put another person who may currently be in a motel into that to transition them out. So we have 6 there, we're at capacity. Haven't been any problems. I know.
Now, do you have caseworker that visits
Yes,
them?
there's a housing case manager that
And was
does.
that the case prior to when they were in motel placements? Did we have caseworkers following
Just the
up?
individual worker, examiner that would work with a case, but not someone that was central and that could actually deal with everybody.
And so what the caseworker's role is to follow up with the people that are in this managed housing if they need resources, alcohol treatment, drug treatment,
Yes.
mental health.
I mean,
Okay.
before her role was she's a case manager for the department,
Okay.
and her role was to get the folks out of the motels. Now her role is more on the front end and to prevent that motel placement. And, individuals who come to us, we work with them for what natural family, friend resources do you have in your life? Where did you stay last night that now you're homeless? We will help them engage in a conversation. Maybe they burned a bridge with a friend or something, where they were staying, we will try to help them work that out so that, to avoid that motel placement. I mean, I think the thing that is, every Monday, they issue a homeless report with regard to motel placement for individuals and families, and we're right around that 10 individuals in the motels, and we know that a majority of those are, folks discharged from the correctional system.
So that's
back
just
into
a
the county.
temporary situation
That's
until you
temporary,
can
but
get them in a permanent
and then with
apartment.
families, in the course of a month, you may get a family who, received an eviction notice and has nowhere to go with their children. And now, when you look at when we discharge a family, the average length of stay in a motel is 9 days, where in the past it was over a year.
And that's a good thing.
No,
I know
right, so we don't like to have the family stay in the motel, but sometimes it's just inevitable, but, within 9 days,
9 days
we're getting
instead of
them
9 months.
back in, transitional housing or
Right.
more permanent housing,
Right.
so.
And I have gotten calls from people that needed assistance and it was taken care of, and I got, follow-up calls back that, things where they were hooked up with resources and services. So, I know there's been some misconceptions about the homeless placement, and I just wanted to clear that up. If anybody has any questions? Anybody have any questions?
And just on the SNAP, which is the, formerly named food stamp, we're still seeing that increase. And that are folks that are not, their wages are not enough to be able to, it's a supplemental nutrition program. It provides more resource to them to be able to feed themselves and their family.
So, it looks like we're moving toward a better situation for homeless people. Giselle, would you agree?
Yeah, definitely.
Okay, could you just kind of fill us in a little bit on what you feel about it?
Well, I feel now that, there's also been a change in just, the culture with the staff as well as with individuals coming in. We have people that are coming in now anticipating that they may get an eviction notice. They're running into some hard times, so they're coming to us now instead of with the eviction notice and not having any place to go immediately, so that we can work on the diversion strategies to get them into a place of their own. We do continue to assist with the rental assistance, cash assistance for those placements, but it gets them into a better place, and they can stay close to the resources, schools for the children. They don't have to be in a motel that's, miles away, because that's the placement that we have. So we see that happening more often. So the case manager also identifies affordable housing with landlords, preferably with utilities included, so that we don't have to anticipate that now there's an electric shut-off or some other emergency. We have, people that come in, and again, it's short-term stays. They do have an income, but they are in a situation right now, so they're coming in for an emergency opening, close, one-shot deal. We'll help them for, 5-day stay in a motel or whatever, and then they're back on their feet. So we see more of, a personal responsibility, like I'm trying to get on my own feet, I need your help for a little bit, and this is the plan that I have moving forward. So it's not, we don't have that 1 to 2 year stay in a motel, which I think we had a parolee who was in a motel for 3 years, and we had families that were in there for 2 years. It just became, that's where kids were growing up. So now they will come to us with a place that they have. They'll come to us and ask if we can help them negotiate with the landlord that they currently have. Some landlords have been great with the inventory that we have in lowering the rent that a person pays, if they know that social services will intervene, and they're worried on the other side about having their places destroyed or having someone just leave and then they get stuck without rent being paid. So they're working with us as well, which I think is helping some of the inventory that landlords have that has been empty.
So you have better oversight of the vendors, because prior to that, we
Yeah,
had thousands,
exactly.
and they could have been placed.
And we've had
elsewhere.
vendors, with our vendor process that have wanted to be landlords, but They, you know, have had negative situations before that, you know, for example, if there was an issue with an apartment and it was condemned, and then we know that that's a landlord that normally has those kinds of places. Through the vendor process now, we can vet that individual, so we don't have those issues on the back end, because there are vendors and landlords that will just leave somebody out in the street.
And that was one of the goals too in prior meetings, was to have oversight of all these thousands of vendors out there. So I know the process that you put in place is what you're describing, a better situation.
I mean, still with the vendors, there, you know, at one point there were 10,000 vendors, and then we looked at, you know, vendors that had not received payment in a couple of year period, and were able to eliminate 3,000 or almost a third of those vendors. And we did not necessarily have the resources to then go and review the 7,000 vendors, but we believe our policy that we put into effect with an annual review of vendors, we will, you know, be able to update information regarding vendors, and through our process will, you know, weed out vendors that we really shouldn't be, you know, utilizing, et cetera. So again, it's an initiative put in process that will be in process for a while.
Better situation for families, for kids, all around. Are there any questions about the homeless? Nancy, Joe, did anybody have any questions? Okay. Okay, number 2, we're gonna introduce our new Adult Care Center Administrator, and we welcome you to Sullivan County, Shanoy Wellington. And if you could give us a little information on yourself, that would be good. But you may have to speak a little bit louder, or come here, so. And I know Debbie DeJesus was looking forward to meeting you and helping you transition, so we thank her for that as well. So Shanoy.
Good morning, everyone.
Good morning.
I take it a privilege and an honor to serve in this capacity, and I thank you for affording me with that. I am basically from Westchester County. I have served in long-term care for over 6 years now. It's a field that I am very passionate about. It's a field that I love. I sincerely have a true affinity for the geriatric population, and I'm hoping that my addition to your team in Sullivan County will be extensive in creating great quality of care and possibly making this county facility one of the best in New York State. So that's my long-term goals in terms of what I hope for. I have served in the capacity as weekend administrator for United Hebrew Geriatric Center in New Rochelle, and I've also served as assistant administrator with National Healthcare Associates, which is a for-profit organization. Again, I'm very honored and privileged to be part of your team in Sullivan County. I'm looking forward to working with everyone. I have seen that Debbie have created great systems in place and moving the agenda forward. I look to continue some of those systems and revamping whatever systems needs to be revamped or changed. There's a lot of changes that has come down the pike on healthcare. There's a lot of transition and culture change within healthcare. Just been to a meeting this past few days. There's a lot of changes by CMS, a lot of changes by IPRO, and I'm looking forward in getting my staff equipped with the resources that they need to provide and deliver the best quality care to our seniors. As we know, our seniors are some of the most vulnerable citizens that we do have. And one day, we all will get there. So it's my intention to create,
We don't skip it.
It is my intention to create a very accountable system where we all can be pleased to say we are very satisfied with, and that the transition of care in terms of within long-term care will be a successful one, and the aging process will be a lot easier. It won't be just filled with illnesses, but it will be a pleasure to grow old, because your county will have a very well-equipped facility to take care of the needs of your residents. Thank you.
Thank you, Shanoy, and I think the communication end is the most vital piece. And, you know, with the commissioner, myself, and with the Family Advisory Council, Advisory Committee, so they had requested to come today and to give a little background of what the Family Advisory Committee does for the ACC. I'm sure many of you are familiar with, you know, their advocacy, because they are a very vital and vibrant group. I can tell you that. And I see that Fred Robertson is not with us today.
No, I'm glad to speak for you.
Okay, so we have Bob Convalin today, and he was going to speak for the committee.
Good morning, everyone. Good morning. I happen to be Vice President of the Sullivan County Adult Care Center Family Council. We thank you for this opportunity to explain who and what we are. The Family Council is an advocacy group for the residents of families, staff, and for the Adult Care Center. And we advocate for the betterment of the resident to increase their quality of life. We also assist families in the transition of their loved ones from home to the nursing home placement. And we support the staff for the loving care of the residents. I would now like to introduce the rest of you to you, the administrative group. We have Joe Heilman, who is our co-president over here. Barbara Convalin, my wife, she's the treasurer. I refer to as Miss Moneypenny. And Gail Fredenberg, our secretary. And Jim Deary, over there with his own chair. He's past president, and his wife, Joan Deary, is past secretary. And I was always told the key to successful public speaking is brevity. So with that in mind, I would like to turn the microphone over to Joe Heilman, who will inform you on our ideas and hopes for the future of the nursing home. Joe?
Thank you. We're here. Can you hear?
Yeah, Joe, can you stand up or come a little forward?
Yeah. All right.
Joe, how about coming over here? These are the microphone.
I got a big mouth. So that's loud enough. Okay. Oh.
Well, if you got a big mouth, you should be sitting with us.
Oh. Okay, thank you very much for having us here. We really appreciate it. And I stick to the written script. I've been instructed to do so, along with Robert.
Not by me.
No, not by you. We are here as members of the Family Council to speak as advocates for the residents of the nursing home. We are an independent volunteer group, and we are here to protect those who are no longer able to speak for themselves. We view the care center as a vital part of our community resources, and that's a word I'll be using over and over. And we expect that it will be maintained as such by the county's governing bodies for future generations. We feel that the Sullivan County owes its loyal taxpayers.
Just paid our bills.
That's all of us sitting here, owes us the security of knowing that we have a resource that we can depend upon when the aging process and failing health fall upon us. The 25 years or so of threats to sell the home has accomplished nothing but undue mental stress to the residents and demoralization of the nursing staff. I was told that the Delaware infirmary had been sold to a private company, and then it's since closed. So I was up in Delhi and I drove by, and sure enough, it's an empty building, and where was flowers and grass is now just empty asphalt with weeds growing up through it. And do we really want that to even risk having that happen in our own county? We at Family Council feel that the Sullivan County Adult Care Center has a great potential to grow and to provide excellence in patients' care, all while remaining under the county's control and ownership. Okay, I just said that, and I'll skip over to the other, so I'll stick to the highlighted yellow. Okay, let us protect and nurture a resource, once again, that is so valuable to each and every one of us in this room. And there will be a time when each of us in our lives, we may need such a resource to be close to our families and to our friends and to our community. Again, the Family Council does not want SAC to be sold. We consider it a valuable resource as much as the clean air and the water we enjoy here in the mountains. We ask you to put a moratorium on the phased sale of the infirmary for 5 years and to fully support the new commissioners and administrators. Although there will be failures, there will also be some new and surprising successes. Thank you so much for your time, and I'd like to thank Mr. Parker for his time he so generously gave our meetings. Thank you very much.
Thank you, Joe.
And, oh, Jim, the best part.
Okay, I got 5 points here that I would like to pass on to you. We need to advertise the Sullivan County Adult Care Home. I've talked to many people, especially in the western part of the county, and you talk about, well, what are you doing? Well, we're with Family Council at the Sullivan County Adult Care Home. Well, where's that? Nobody seems to know. And sometimes if you mention the infirmary, well, then they know that, but a lot of younger people don't even know that. So I feel, and we feel that we have to advertise, and we should list SCAC's strong points. We have a new update Alzheimer's unit. We have a rehab unit, a respite care, adult daycare. Again, many people are not aware of these different departments within the SCAC, and now we're the first in Sullivan County to offer a new secure Alzheimer's unit. This is important to get out so that people know. With the new rehab unit, we must make sure that we have equipment so that we can be competitive. The other thing that we need here, we need signs strategically placed, for instance, at the corner of Route 52 and the Sunset Lake Drive. We also need signs, I believe, on Route 17, northbound or westbound and eastbound, probably in the proximity of exit 100. The signs should, again, should read, Sullivan County Adult Care Home with the address, and that we offer, home nursing care, Alzheimer's unit, rehab unit, respite care. When people drive past, they're gonna see the sign. Down the road, they have a loved one that needs to be placed in a facility. They're gonna think about Sullivan County Adult Care. Right now, if they don't know it exists, they're not gonna think about it. It pays to advertise. Hopefully these signs could be provided by the county and installed at whatever locations would be available. In the past, Debbie DeJesus brought about a positive change to the facility. In the last year, she has done wonders. You walk into the facility, people are smiling, they work with one another. We have to continue that positive attitude. Punitive does not work. You keep yelling at people and they're gonna do just the opposite. In keeping with the positive, we must be able to commit to a long-standing period of operation. If we can commit to that, we can bring in skilled employees that will be willing to take the job because they know, they have a future in the job. They're not gonna say, well, I'll take the job, but I suppose in 3 months or in 3 years I'm out. You can't get good employees if you can't guarantee them a place to work. Now, the other thing that we need to do, and as with any business, you have to kind of work at it. And we need to do proper documentation because that's going to bring in huge amounts of money. If we don't document what we're spending, we can't get the money from the insurance companies and so forth. And we, in our discussion we feel that Randy Parker is extremely knowledgeable in the field, and he has many years of experience, and he can be extremely beneficial to Sullivan County. And we would like to thank Randy for all his efforts and his support. We have been very fortunate to have a supportive legislative group who has worked for the betterment of the nursing home, and I would like to thank you all for your efforts. Thank you.
Thank you, Jim. And I think that this board, I'm not speaking for everybody, but we've moved ahead with the HEAL grant, the Secure Alzheimer's Unit, capital improvements. We're in the process of the roof project. We've done renovations, interior work with the lobby. So I want the board to think about committing to that 5-year moratorium, and the new administrator on board, work with her and see what other ideas we can come up with. I believe that when Debbie was here last month, she talked about a long-term plan that she had proposed. Is that carried over? That's going to be carried over? So do you know anything about that, just in a nutshell summary, or maybe next month?
Maybe next month.
Okay.
I'm actually in the process of analyzing what the long-term plan is, and to see how we can integrate some of the new changes by the government into some of those long-term plans, and maybe cut back and try to reduce the cost that it will ensue in getting some of those things done. So I have not yet completed my analysis. I will be meeting with my staff on Monday to try to get a solidified plan in place as to how we're going to proceed in going forward.
And I know with the marketing coordinator now on board, she'll have a role in advertising and marketing. I did have a conversation with DPW, Ed McAndrew, and he's going to fix your sign at the end of the road, and we'll also be in conversations with DOT. Route 17 is a proposed interstate, so there's some, questions about signage there, but we'll follow up on that. And I don't know how many of you here were aware, employees obviously there, that, like Jim said, not only is there a daycare program, but a respite program for those that need a break, right? Physical therapy, occupational therapy. So I think that's all going to be inclusive in that marketing campaign going out. The positive work environment is something that I've heard not just from Jim today, but from others as well. And also a conversation on updating equipment in the rehab. And I think, Randy had spoken about that, and the council as well. So we'll be going over that with Shinoy. And then next month in November, if Shinoy can come back with, a nutshell summary of this long-term plan, and then, for the board to think about a commitment for the ACC. And I know that the board has been supportive in, making that commitment. So. Any questions? Okay. Thank you.
Thank you.
Thank you very much.
You can stay if you like, or you can leave if you like. It's okay. We won't be
They're
offended.
busy folks, they got lots of things. I know the two of you, I'm not sure about the rest of them.
Oh,
I know the
they
two of you
teach
are
us.
out there doing something.
Okay, we have two discussions. Nancy McGraw, I had asked her if she would attend today to talk about quality improvement programs throughout the division. There's been some requests for trainings, New York State trainings that can be brought into for best practices, quality improvement. I know some of that training the commissioner has already instituted, which he can speak about when he comes back in. But Nancy has already instituted some programs in her public health department, so I thought she was a good one to come and kind of explain what it is and what needs to be done to move that forward.
Sure. I'll start with just reminding everybody that it's flu season, and you should get your flu shot. We, good for you, I did too. We do have flu vaccine, and we're rolling out our flu clinics in the towns. And the reason I bring that up is because it's directly related to quality improvement. Yesterday we were notified by the State Health Department that New York State has received some wonderful awards, which I shared with the legislature, for its stellar immunization rates for children and adolescents. And Sullivan County has, public health has done a lot with local providers and with our immunization clinics at public health to really make sure that folks who may be underinsured or don't have a regular provider are getting their vaccines. So I just wanted to share that. And that's on behalf of the staff. They do a lot of hard work in terms of outreach and clinics.
And working with the local doctors too?
Working with local doctors to ensure that they have the immunizations that they need for
That's
families.
great.
And they also provide outreach to the duck farms and the chicken plants and to folks that don't normally have a regular healthcare provider. So we've been doing, as a health department, quality improvement activities for many years. It used to be called quality assurance. Quality assurance is a look back. Quality improvement really is the new terminology for where we're going forward today. And quality improvement basically is using a process and a number of tools and methods to improve your programs, improve your services, take a look at what's working well, and let's keep doing that. What's not working well, how do we improve the services that we're providing to the public? So each of our programs, most of them do have already quality improvement pieces built into the program. For example, our Healthy Families Home Visiting program has certain benchmarks and standards that the staff have to meet. So, for instance, making sure that families have their children's shots up to date, that women are going for prenatal care on a regular basis, that people are seeking employment and are seeking permanent housing. Our WIC program focuses on height, weight, hemoglobin issues, lead poisoning prevention, making sure that children are getting lead tested at age 1 and 2, making sure that women have the proper nutrition that they need in order to have a healthy pregnancy and a healthy family. So the quality improvement tools are built into their work that they do every day. Some of it is required by the conditions of the contract or the grant or the funding source. And some of it is above and beyond and is what we do as a health department. I'll give you a couple of examples. Last year we implemented, we centralized, and it's in our monthly report here in terms of highlights. We've made some significant reforms in terms of centralizing billing for our long-term care and our certified home care agency. Our staff meet on a regular basis to discuss financial issues, billing issues and problems, to resolve the workflow and the process in terms of when we get a referral, we need to make sure, for example, that we have the correct insurance information, that we have everything we need so that when the nurse goes out to the home and makes a visit, that we have authorization for that visit and that we know that we're going to get paid. So we often use, what we've done in the past is use a workflow like it's like a business process analysis. And it's a tool that we use when we meet with staff on a regular basis to discuss, okay, if we're not getting the correct insurance information, where is this falling through the cracks? At what stage? Is it when we get the referral, or is it because when the nurse went out to the home, she's not getting the correct billing information? What's the follow-up for that? So we've been able to resolve a lot of issues that way. to increase revenue, to make sure that, that we can stay in business and continue to serve the residents that we're serving. So that's the short explanation of quality improvement.
So are there a number of trainings or programs, or is it kind of a blanket quality improvement program? Or is it kind of tailor-made for each department?
It's pretty much specific to each program within our department,
Mhm.
but then overall, as a health department, we need to position ourselves for accreditation. And accreditation is a national benchmark, and the New York State Health Department has just become accredited. And they're going to be moving in the future towards expecting local health departments to become accredited. And the expectation is that at some point in the future, it may be tied to our state aid reimbursement and our competitiveness for grants. So while we do have quality improvement activities going on and built in within each of our programs, overall, as a health department, there's more that we need to do.
Okay, so I just had another question that I wrote down. So
And
does it?
I'm sorry, I didn't really address your question about training, but training is a very important piece
Is that
of-
separate, or
of
is that a part of it?
It's built into each program specific to their
So you can
job.
kind of tailor-make your trainings for the program?
Yeah, a lot of the training is required by the state,
Okay.
specific to, we have staff who work with communicable diseases, and they have to get specific training, and the state provides that training. So it's an ongoing,
Okay, so the
Process.
required training is what you're doing now, right?
Mm-hmm.
And is there additional training that could be utilized to resolve issues as well? Or
I
does
think
that?
there's always opportunities for additional training for staff. I think quality improvement is directly tied to the quality of your staff.
So within your department, does it increase the staff's workload? And is it a specific staff that implements the program?
Really, the supervisors, from the supervisors to the frontline workers, everybody is involved in the process. But in terms of pulling it all together and documenting what we are doing as a health department overall, that's why I have requested a quality improvement coordinator for the 2015 budget, actually for the second year in a row, because we do need to position ourselves for accreditation. There's
Okay,
no
now-
one individual person who has the time or the resources to do this.
Now, that request for the coordinator, is that specifically just for public health? Or would that be
Yes.
over the county as a whole, or that it's not normally?
I think that person would have more than their work cut out for them just in the health
So
department.
each department. So as far as the division as a whole, I know Giselle or Randy, you had instituted some recent training.
I think at DFS, we have 51 different programs being provided, right? So when you look at quality within each specific program, that, usually accreditation drives quality, okay? And any body that accredits an organization, has a significant quality, a CQI, continuous quality improvement process. I can speak to Ohio's child welfare system, where they are actually, most counties now are accredited by the Council on Accreditation out of New York City. The acronym is COA. Within accreditation, you have certain infrastructure requirements in your organization. You have to have a clinical services department, you have to have a CQI coordinator, you have to have staff with certain credentials, you have to have supervisors with credentials, you have to have worker to caseload ratios in order to maintain your accreditation. And then there are standards of excellence within each program that you offer. So if you take a child protective investigation as an example, you're gonna look at it, we get 1,500 a year. Our approach in those 1,500 investigations should be uniform, consistent, et cetera, should operate with X number of staff who have no more than X number of cases. In New York State, Office of Children and Family Services with Child Protective gives us a monthly report on 3 different indicators. But those indicators are number of workers with more than 15 investigations, number of overdue investigations, and then number of 7-day safety assessments done on time. And that's the only 3 indicators. There's a whole world of, Child Protective other than those 3 indicators. So I think what is driving New York State Department of Health is talking about, best evidence-based programming, which is researched with control comparison groups, et cetera, promising practices. So I think DOH is ahead of probably other state departments in their insistence upon quality. So, for Nancy, with the number of programs that she has with a CQI quality coordinator, they will set up an infrastructure in the programs, but training becomes a part of it when you identify in your system, where maybe your strengths and weaknesses are. And, in a recent food stamp audit that we had, the state came, they reviewed 33 cases. We had a situation where there was one form that was missing in 32 of the cases. So that tells you, that's a training issue. If that's a training issue, the supervisor of those folks gets those folks together, revisits the procedure that's in place, you correct that problem. So it's, it's a continuous loop in terms of what you're doing. Government entities don't tend to fund quality initiatives. State departments don't necessarily fund that quality. But in Ohio at the time, my board was supportive of it, but it was expensive to be accredited and to maintain that level of staffing, et cetera. But there was a commitment to it. New York State has no such accreditation in any county in its child welfare
So I guess I'm just trying to understand what the scope of trainings there are and what would be needed initially.
It depends by program. It depends on, it could be in a HEAP
So
program.
it's not across the division, it's by department.
It could be.
DFS would be different than public health.
If someone would give us X number of dollars, you could have a department within the division, which is a quality assurance department. That could set up certain infrastructure within each department in the division. I don't know where that money is necessarily gonna come from to set up that department. I think what Nancy wants to do is I think Nancy did that, much of it in her deputy capacity when she was a deputy, when Carol was the director. But I think for her department specifically, it's a place to start with the quality.
So would it be possible maybe for November to have some of the departments, I know Joe is here, Nancy's here, Giselle, maybe have them come in and kind of give an idea of what kind of program you would need, because it sounds like they're all different. It's not an across-the-board program or trainings.
And if I might add, as with Randy and Nancy was saying, within our department we have continuous quality assurance measures that we look at, and we make sure that things are going on, and on an annual basis we do satisfaction surveys with the people who participate in some of our direct care services, our client-facing stuff. But the other role of a local government unit is to actually go out with the state and do some surveys at the certified agencies that we have. And right now, Melissa, my deputy, and I are splitting ourselves to go ahead and go out there and do that, or at least the entry and the exit interviews. And we get copies of all of the state surveys so that we can kind of look at what's going on. But at one point in time, the Community Services Department had 3 community services coordinators who would cover mental health, developmental disabilities, and substance abuse services. We now have none. So the job's a little more difficult.
So it sounds like that's a piece on trying to get feedback from, who you're serving, right? But there's also the piece, like I think Nancy had mentioned, about the financial end and the billing end.
Right.
And then there's also the piece about, interpersonal you know, relationships among employees, right? Is that a part too?
Yeah.
It's all of it, it's really all of your operations.
But I know, but
And if
what-
you looked at an area, if you look at the food service within the ACC, right? So you would wanna look at every aspect of it. You look at the staffing, the quality of the staffing, the requirements of the staffing. You look at their workflow, their work processes. You know, they are making X amount of meals per
I
day.
guess what I'm looking for, because instead of, you know, as a whole, a program, which you say could be costly, what I'm looking for is the departments, and Nancy, you know, she's got her priority issues that she's trying to cover with her program, and Joe has his, and I don't know about some of the other departments, so maybe next month we could just have them come in and say, these are our priority issues, and we're using this program or this training to deal with that, right?
Well,
And
there are
that they
several-
should match
There are
with,
several required trainings that each of us have to do based upon some of the state regulations
and
that
now
are
you're
there.
doing already.
Yeah,
That
that's
we're
the
already doing,
mandated-
and
That's
then
the
there are,
mandated training,
Yeah.
you know, CPS, before you can have a caseload assigned to you, you have to have 4 weeks.
So if we're
before.
doing that already, then I don't really wanna discuss that, but I'm talking about if there's issues in the department, you know, like Nancy has issues with the billing, so she's using her program to address those issues. But there might be a department that has, you know, different issues, you know, maybe with the employees, or maybe, you know, whatever it is.
And the other, I think the greater factor that we all, you know, particularly in the health department and behavioral health, have to think about is, you know, right now we're going through a great convergence of the Affordable Care Act within all of the health field. And right now, I mean, what we typically had looked at in the past was, you know, units, the number of people you saw, how many of them you got through, how long it took, stuff like that. Where now the Affordable Care Act is forcing us to look at qualitative measures, such as, you know, what were the outcomes? You know, how has this person's, you know, wellness improved? And those are the things now that we're going to need some assistance on in terms of our ability to continue to play in the health field as we go. And a lot of it also is talking about, you know, how do you share, you know, the data that you have with the other providers for that individual. So when Cindy goes to her doctor, she can also see, you know, her doctor can also see what her, orthopedic issues were, and whether she went and received some help from that pain management doctor, and what she's doing that way. You know, so those are some of the qualitative measures that are going to be coming that I don't know that we're that prepared for.
So that's gonna change,
But
and
it's all
that'll
gonna change.
evolve.
Yeah.
Right.
Yeah.
So, okay, I got it. So for November, I'm just gonna ask, you know, maybe Randy can get that information from the departments. If they have issues, and communication with the employees as well, they might have different issues than, you know, management has, you know, and so that should come forward in a priority, and then we can look at what kind of quality improvements to put in place. Does that make sense? Okay. Are there any questions?
Yeah.
Jean?
The flu immunization clinics, are they done in all the townships in the county?
We used to do them in all the townships. We, a couple of years ago, started to scale back and concentrate on the most
right?
need, and the clinics with the highest numbers of people who are attending. So I believe yesterday our staff just released the list. So most of the towns are covered or close by.
Okay.
There were some clinics where we only had 10 people show up 3 years in a row, so, but I believe we're still doing about 6.
Okay, thank you, Nancy, and thanks for coming to talk about that. Okay, and our last discussion, Office of Children and Family Services Blueprint for Child Welfare.
Okay, that attachment did make it to the agenda, but I can bring it in November, and it's just New York State Office of Children and Family Services, who, you know, New York State is state supervised, county administered, and it's child protective and foster care. So OCFS, the acronym for them, has been working on a vision statement and, you know, kind of operating principles. It's a, you know, pretty thorough document that they're in the process of finalizing it. And it's really how they expect counties to approach their child welfare system. And it's a blueprint, so we can bring it in November and just go through it. And I think when it becomes a finalized document, the state will be asking counties to, either yay or nay it in terms of endorsing its content.
So what's the intent of that?
The intent is you have, how many counties in New York? Is it 58?
62.
62.
They have the 4 out. The boroughs out one.
There's 5 boroughs, not 4, but that's okay.
So, they want uniformity in child welfare across the state, whether you're in Orange County, Sullivan, Ulster, Dutchess, in terms of how they approach their child protective cases, foster care. It speaks a lot about foster children, foster families, how we, approach them, support them, treat them. Permanency for children rather than children drifting in the child welfare system, and how you kind of go about doing that. So it's a pretty neat document. I think it's been 2 to 3 years in working on it.
Yeah, I haven't been able to see that document, so I'll look forward to reading it, but, from what you see, have we moved in some of that direction
Yeah,
already?
yeah, definitely.
Especially in foster
Yeah,
care?
Yeah, I think across the board we have.
Big reforms with this legislative board. And I want to thank my colleagues for the support, with the reforms in the division. There's been a lot.
Those 3 indicators in the child protective that, I spoke of when I first came, we were, it rates you by county, and we were consistently in the bottom 5 in the 3 indicators. And, I just got August report, and we're in the middle of the pack now across the board. So we have shown, just in those 3 indicators, improvements. But I think what helped us in CPS the most was the legislature authorizing the 3 senior caseworkers in the 2014 budget.
Absolutely.
So that allowed us to go from 15 investigators to 18, and that helped tremendously in being able to respond to cases on time and to be able to close investigations on time. So that was great.
And I
That was helpful.
received thank yous from school personnel, from educators, that we're moving kids in safer environments. So we're in the right direction there. Okay, so we'll get more information on that in November. Are there any questions about that document? Okay. Kitty?
I wanted to ask a question, I think directed to Nancy. I'm looking on the back here, the Sullivan County Public Health Services regarding the rabies. Is that an increase, a decrease? It seems to me rabies-related incidents of 38 seems a little high to me. And only having 1 rabies clinic and post-exposure prophylaxis.
Yeah, those are kind of separate numbers. I'll explain. Last month I was at the Public Safety Committee to talk about rabies and how important it was for people to be more aware of making sure that their pets are vaccinated, but that they don't also take in stray animals or go near wild animals or animals that they're not familiar with. Exposures, the incidents are potential exposures. Those are not necessarily the number of people who end up having to be treated. Those are phone calls that we get, I was scratched, or I was bit, or, not all of those people end up having to get treated. With that being said, we do free rabies clinics 4 times a year with our veterinarians. And we have hundreds and hundreds of people that bring their pets to get them vaccinated. So that's the clinic issue there. I do want to say that there was recently a positive cow that was tested positive for rabies, and several people were exposed trying to handle that animal and put it down, and those people are being treated. So even with domestic animals and farm animals, people have to be careful. that if they see an animal that's not acting right, if it's having neurological symptoms, not eating, not drinking, it's possible that a wild animal wandered into the pasture and that had rabies and bit that farm animal. So people need to be very careful to use protection, to wear gloves. So we're continually trying to do health education and awareness with the public.
And I think
our
that
staff get a lot of calls.
Nancy, am I right, that 185 number of animals receiving, the animals receiving?
Yeah, that was just for the month of August.
Okay.
That was for the one clinic, 185 animals.
But that doesn't mean that they just, okay, yeah.
Those are rabies
That was the
vaccinations
clinic,
as opposed to
right.
Vaccinated
treatment.
against
Right.
rabies, right.
Thank you.
Because it's out there.
It's on the increase, rabies in the county?
Well, it's always been out there. I just think people need to be more careful so that they don't expose themselves to a potentially rabid animal.
Thank you.
Okay, any other questions? Any other reports? Lesha or Joe, anything? Joe, you were at NISAC?
Yes, it was.
Was there any, update that would affect the county?
I'll bring that back to you next month. But there were several important resolutions that went through, and you know, I'd like to bring them to the board so that they can look at them. I did do a presentation with the Erie County Public Health Director on what can counties do with regard to prevention and treatment of people who have opioid or heroin addiction issues. In the back of your program is the PowerPoint that just kind of talks. It's an addictions 101 kind of presentation that I also did for the probation department because they have some new folks there. But I also used that at NISAC to talk a little bit about, you know, what are the three elements that need to converge in order for a chronic disease to occur. If you want it, I can do a presentation on that for you guys later, or you know, if you read through it and it looks like it's great and you get it, that's cool too. But I thought I would attach that to have that.
I brought back the whole packet of NISAC resolutions from all the different committees. Annie has the copy of it if you want to see it.
Okay, thank you.
And it's also available on the NISAC site.
Yeah, it's on the NISAC site, and it will also be mailed to all the legislators who weren't able to attend.
I would just ask is, when it comes to addiction and the heroin addiction, when John Bonasek was here a while ago, one of the concerns that was raised is the advertisement abilities of the pharmaceutical companies on mass communications like TVs. Is the state and or any direct group doing anything to stop that advertising? We succeeded in doing that with smoking. Joe Camel and the rest of those guys can't be on the TV anymore. Is there anything going as far as pharmaceuticals? Is there any movement in that?
I'm not aware of any state initiatives, and I am aware that, you know, the ability, we're one of the few, you know, countries that allow
Right.
for pharmaceutical advertisement to happen on
Right.
commercial TV, radio, or whatever. And I do know that that's a federal statute, and I think that it would behoove us to probably address our federal, legislators with regard to this as an issue for us, because, you know, quite frankly, it's a huge issue. You know, unfortunately, the advertisement has led to this belief that, you know, all I have to do is take a happy pill to achieve wellness, and that's not the case. Wellness is a life practice.
Is there a way to help make that happen? We are one of the few countries in the world that allow this, and I do believe that someone needs to start spearheading with a direction.
Priscilla,
that.
did you have something to add? Oh.
Well, I'll speak during the
Okay,
public
Alan?
session.
Yeah, I can speak a little bit to this. I actually met with Congressman Gibson probably 2 or 3 weeks ago to discuss this topic, and he's put me in touch with one of his staff members. The protocol, I get from what I understand, is that Congress needs to revisit the legislation that authorized pharmaceutical companies to do direct-to-consumer advertising in the United States to begin with. And the protocol is, after a number of years, when a bill is passed that allows this activity, there is a period of time where Congress can take a closer look at it to see how it's working. Are there any unanticipated consequences as a result of the legislation? I think it's pretty clear to me that there are unanticipated consequences of direct-to-consumer advertising. And, you know, anytime I, you know, watch television, I just increasingly, you know, distraught by the fact that these pharmaceutical companies are, you know, basically encouraging people to get on prescriptions. There's illnesses that I think they make up.
So what would
for
he
the
need
sake of,
to follow up on it and move it forward? What would he need? Would a resolution from the county board or something?
It's gonna go,
Oh, that was the
it's
end of it.
gonna have to happen at the congressional level. I'm going to be helping to gather some data, background data. And then he's gonna have staff working on it. But that's where it has to take place, is at the congressional level.
Okay.
Because
We
it's
need to
Congress that
create
authorized it.
We need to create a groundswell, and I think it behooves us to do that since we have such a addiction problem in this county.
Is NISAC addressing that? Does anybody know?
Yes, it's in the resolution
Right,
packet.
so that would probably be the channel as
And
well.
we also passed a resolution somewhere between 6 months and a year ago about this.
Yes, we did.
So it needs to be followed up, and through NISAC, and Alan, you're in communication with Congressman Gibson, so you can give us an update at some point? Okay, maybe in this committee?
Sure.
I do wanna say that.
November, December, when do you think?
Give me a date, November.
November committee? Okay,
Okay.
thank you.
Nancy had something to
Nancy?
say.
I'll let
Sorry.
you know who I spoke to and what the next steps are.
Yeah.
I just wanted to mention that our last drug take-back day, last Saturday, we took in over close to 200 pounds of prescription medications for safe disposal. So it's working. You know, we're trying to get them off the streets and out of people's homes. So over the last year and a half, I believe our total is almost close to 1,000 pounds of medication that's been taken to incineration. And we have the 24/7 drop boxes.
And I know increased law enforcement as well. There were recently arrests in Jeffersonville over by me, which was in the media yesterday. Alan?
One other thing. I know it seems a world away, but I think it was kind of a wake-up call a few days ago when they found a case of Ebola in Texas, in Dallas. I guess it seems to me, just following the coverage, that one of the reasons it kind of slipped through the cracks may simply be that someone at the hospital just wasn't aware, you know, that there was a geographic isolation to the disease, and so when a person mentioned that they had come from Liberia, they just didn't mean anything to them. So I guess to what extent can we, you know, just educate and reach out to the nursing staff to make them aware, you know, that someone coming in with certain symptoms from a specific geographic area, that's kind of a red flag that comes up.
And we have major
Yeah.
airlines here,
Yeah.
New York, so.
Well, I can address a little bit of what's being done on the federal, state, and local level in terms of awareness. And emergency preparedness is a very important part of public health. And with hospitals, nursing homes, health departments, and we are constantly, you know, we have these secure data systems that we're required to check every day, and we get alerts. And so there's been a lot of education and awareness that's been done with hospital staff. They get alerts and advisories and updates and notices constantly, like 3 or 4 times a day. Not just on Ebola, but everything, anything communicable that could be a risk. And so hospitals across the country are on alert, and staff have been informed and educated, as well as our health department. We just had a staff meeting yesterday and talked about Ebola and all kinds of other enterovirus, which is affecting a lot of children across the country. We don't, you know, it can be kind of tricky because in terms of the awareness and education, because it's disease specific in terms of how things are communicable, how do I say that?
Communicable.
How things are transmitted. Some things are person to person, some things are not. So it depends on the disease that we're talking about, but there's a lot of preparedness and education that happens every single day.
Thank you, Nancy.
Yeah.
Okay, Karen, I didn't want to leave you out. Did you have any
I
updates?
want to thank you for stepping in to do a public service announcement for the RSVP program for medical transportation. We actually have 3 new volunteers for this month alone, so it's actually going very well. We're still looking for people, so anybody who knows anybody who is 55 or older who would like to do medical transport for RSVP, please let them know and to contact us. Seniors helping seniors. So that's a wonderful thing, and we thank you for that. And I think that's about it.
Okay. Are there any questions? Public comment, Priscilla?
Yes, I can't speak very well, but I must tell you that SLAC has worked with the Family Council, and we're very pleased to hear this request for a moratorium, 5 years, on discussion of any sales. This would really give great stability to the evolving quality of the adult care center, and I'm really delighted to hear this and hope it will fall upon not on deaf ears. Especially in as much as when most of the, I think all of the legislators who are now serving had committed themselves to the adult care center. It's been through rocky times, and now this whole question of stability is fairly obvious, and there's a new roof going on, and I feel this is the time to make a public statement. Especially, we're very concerned about what happened in Delaware, and I'm glad that Randy had nothing to do with that.
No,
I
give
No,
Nick
Randy's
for
on our
side.
We're glad about that too, Priscilla.
But we know what's the boomerang and so forth in Orange County. We are a different facility from Ulster County, Orange County, and many of the upstate facilities. And we're a stable, wonderful facility for all of the futures of all of our residents. We never know what's around the corner. I also want to say that on this question of advertising of prescription drugs, SLAC from the very beginning endorsed legislation, and it's kind of fallen off the table, and I'm very glad to hear that it's bubbling up again. And we will certainly work with you, Alan, and Statewide Senior Action Council, which is an independent statewide advocacy group of which SLAC is an affiliate. They have long been advocates. I mean, it's really absurd, and we put up with this every evening on the evening news when we see these ads. And they're not particularly for prescription drugs, I mean for dangerous drugs, which we're talking about, but just in general. It's insulting to the intelligence of the American people, and it's time that we took ourselves away from New Zealand, the only other country. I can't understand that.
Thank you, Priscilla. Any other public comment? Ken?
Yes. First of all, what I want to talk about is what Nancy has been about quality assurance and quality improvement. And I give quick background is I used to be a USDA inspector for egg products. Government has its own level of quality assurance, and then I went on to the private side and became quality assurance, quality, whatever you want to call it, on the private side for the same place I was inspecting previously. And when you go for accreditation, it's always a third party that grants it. And every part of the process has a benchmark that you have to meet. And when it comes to food quality or healthcare or any other way of measuring it, the cost is always borne by the provider. you don't get reimbursed by Nestle's because you're selling to them or want to sell to them to meet a benchmark. So that we always have to do. As far as training, the nice thing about accreditation is you got, like in food, you're gonna have transportation. There's certain benchmarks you have to have within that transportation sector. Those become the things you aim for. That's your improvement. Your assurance is your paperwork to show that you've done it. So that's where we have to go to, and it gives you a direction to get there. And you reach that or you go beyond. And so those are the benchmarks. And when you find you're short, that's when you train. It's not to find fault with anybody, it's to make you better, to improve it. Because it's like the guy on the corner who's making baking, and he's got his own way of doing it. But if you want to sell that baking to Walmart, they're going to make you jump through different steps. And you're going to have a third-party audit, and you're going to have to, or verification, or be blessed by them, and you got to meet these benchmarks. So it's not a daunting task. It's a work in progress all the time. And yes, you do have to have somebody who is responsible for that, because there's so many pieces to pull together and to make sure the paperwork is done on time, the paperwork is in place, and there's somebody to follow up and make sure there's training. So we have to march in that direction. If New York State is going for the accreditation, we have to march in that direction. Everybody's going to have to march the same way to get it. And in the end, that will also affect how we get reimbursed, because the feds are going to say, well, if you don't mention, you're going to get reimbursed less because you didn't get there. So that's going to be how we're going to get paying for the funding, is making sure we reach the benchmark. It's not daunting, it can be done, but you always go by the accreditation. Probably the one New York State City is the one, or one New York City who does that. You go to the website, just like with AIB or American Institute of Baking, you see their booklet, and you go for it.
Thank you, Ken.
You're welcome.
Any other comment? Motion to adjourn?
Jonathan Ira.
Annie wants a bagel.